And with that, I am going to go ahead and introduce you all to Maureen Howes. Maureen has been a dental hygienist for 40 years. The first half of her career was devoted to clinical practice and academia. And in 2005, she took a leap of faith and joined the DSO movement of Aspen Dental, where she spent 17 years as vice president of hygiene. And in this role, she supported over 1,400 hygienists in over 1,000 practices, and she mentored a team of 40 hygiene directors and managers. While at Aspen, Maureen facilitated the implementation of AI-assisted voice-activated periodontal charting. This exposure to the world of AI led her to her current role as principal hygiene consultant on behalf of Denti.AI. Maureen is also an examiner for CDA, REB, and CITA. And Maureen, it's so great to have you here. And I do want to give a shout out to Denti.AI for supporting this course today.
Thank you. Well, good morning, good afternoon, depending on where you're calling in from. And I certainly can see that it's from everywhere. I couldn't be more thrilled. As a nerdy hygienist, I am so excited that 1,300 people want to join me on a Friday to talk about perio charting. This is like a hygienist's dream. So thank you for being with me. As Dr. Rowland mentioned, I picked the title, Everything You Wanted to Know About Perio Charting, but we're afraid to ask because we find a lot when we're talking about Denti and our AI software that folks have as many questions about basic perio charting as they have about AI. And so I thought, let's go back to the basics. Let's talk about good old comprehensive perio charting. And then fortunately for all of you, I know the reason you probably dialed in is you're excited about AI and what my colleague Shelley will talk to you about at the end of my presentation. So again, thrilled that you are here with me, and let's get into it. As Dr. Ellen mentioned, we did receive Dental Academy received support from Denti for this course. I am a paid consultant for Denti, and I have received an honorarium for the presentation, but I want to assure you that all the information that we're going to talk about is germane to whatever practice management system or however you are currently charting. So the information is going to be applicable regardless of how you're currently charting. So let me tell you a little bit about me. You heard some of this in the introduction, but I want to tell you what compelled me to talk on this topic. I've been a hygienist for 40 years this year. Spent the first 20 years teaching in a community college and also working in clinical practice. Unfortunately, here in my hometown of Syracuse, New York, the hygiene program closed in the early 2000s, and it caused me to say, what am I going to do for the back half of my career? And I took a leap of faith, joined Aspen Dental as the director of hygiene at that point. When I joined in 2006, there were 70 Aspen offices and 70 hygienists. When I retired 17 years later, there were over 1,000 offices and over 1,400 hygienists. And I share that with you because it's so much of why I feel passionate about perio. I have years of working with offices and dental teams and hygienists and patients, and so much conversation around periodontal disease and trying to help patients understand the significance of the disease. And so much of what I'm going to share with you is some tales from the road and what I've learned from working with hygienists, doctors, and insurance carriers. So I wanted you to have that as a bit of a backdrop. I also want to be very transparent that I know people have very strong opinions about dental support organizations. So please stay with me, even if you're not a DSO fan. There's so much dental need. There is room for all of us in this dental industry, and patients need us regardless of our dental model. And I'm certainly proud that my hygienists at Aspen were really pretty diligent about their perio charting. I held them accountable for charting because I feel so passionate about it. And because I knew that with staff shortages, it was getting harder and harder for them to perio chart. That's where we integrated Denti.AI perio charting, voice-activated perio charting to make it easier for them. I recognized we were asking more and more of our hygienists, and I had to throw them a lifeline and allow them to have an easier way to do the perio charting. But again, very proud of what they did, and it fueled my passion for this topic. Next to my beautiful family that you see pictured here, Perio and perio education is probably what I'm most passionate about. I'm certain that that means I need to get a life, but that's a whole nother seminar. Again, thrilled that you're here with me and hope that you find some nuggets in the presentation that you can take back for your practice. I really want to tailor the content of this presentation to the needs of the audience. So it's going to be really helpful for me if you will jump on the survey question and indicate for me what role you play in the dental office.
Hi, everyone. As Maureen mentioned, there is a survey. So the first question is on the screen, and you can access that right from your device. Right now, we're at about 57%. Let's give Maureen some help here today and get this at 100%. And again, for those of you that just joined us, be sure that you have the handout. The instructions are in the chat area for you. Great, we're at 64% here, Maureen. Let's give it another seconds or so. Everybody's getting their coffee in some areas of the world. We're getting ready to go night-night.
Well, you want your voice to be represented, so please chime in. It's as easy as clicking a button, so please let us know what your role is.
Absolutely.
And I want to make sure as I understand how many dentists or hygienists or office managers we have, then I can try to include information that I think will be particularly relevant for you. So I appreciate you sharing your thoughts.
So it looks like right now dental hygiene is coming in #1. And we're at 70%. All right, we have 15 more seconds here, everyone.
You can do it, folks. Let's get there.
You can do it. 30%. This is part of your interaction here. It's live interactive today. So those of you that asked if it's live, yes, and here is one proof of that. So please make sure that you answer the survey. We're going to wait. Go ahead, Maureen.
Yeah, I was going to say, unless you're driving and you're putting yourself at risk, don't do that. But otherwise, go ahead.
let's not do that today. All right, we are at about 73%. Let's go ahead and end the voting, Maureen.
Perfect.
And we'll share the results. I'll let you go ahead and review them, and then we'll get back to your presentation.
All right, so it looks like 51% are hygienists. That's great because the information is particularly important for you. 16% dentists, and we have some dental assistants as well. So again, dental assistants, thank you. You're such a critical part of the team. I'm thrilled that you're here learning more about perio charting. It's fabulous. All right, so let's talk about what I'm hoping to accomplish in the next hour. I want to describe the current state of periodontal documentation, really identify what the problem is. I'm sure for the hygienists on the call, you have strong opinions about what the problem is and why we struggle with perio documentation, but we want to do a deeper dive there. We want to talk about the standard of care in dentistry, but more importantly, what does that standard of care for periodontal charting look like? It's a question that I get asked often. We're going to tackle that. And then we're going to get into some of the clinical parameters. And I want to be very clear here that my goal is not to patronize anyone. When we review these clinical parameters, I'm doing that because many of you, while we have trained on our Denti.AI software, have been honest and transparent and vulnerable, saying, I don't remember how to chart that. I don't remember the classifications. I don't know what I put in that box. And so hence the title, Everything You Wanted to Know, but We're Afraid to Ask. So we'll touch on those clinical parameters. We'll also talk about how the data you gather on your perio chart relates to AAP guidelines. What do you need to stage and grade, and how can we do that more simply? Then we're going to talk about coding for periodontal charting. Can you use the 0180 code and get reimbursed for it? So we'll touch on that. And then we're going to end on a high note because we're going to talk about the benefits of perio charting and what the future state of perio looks like. And there's some exciting things that certainly in most of your lives as a hygienist, the future is bright about what that perio documentation can look like. So that's what I'm hoping to accomplish. Okay, next interactive part. We're hoping for even more than 76%. I want you to take a guess here. Across all dental practices, I think it's going to come back up here. Across all dental practices, what would you guess is the percentage of charts that have a comprehensive periodontal record? So hang tight. I think that'll come back up. Okay. So again, across all dental practices, what percentage of patient records would you guess contain a comprehensive perio chart?
And you can answer by tapping on your screen. So for those of you that are writing it into the chat area, we appreciate it. But if you'd like to be counted with the rest of the group, go ahead and access it from your screen. So we have the crowd is much more awake now.
They're caffeinated. They got the first sip in.
Exactly. That's great to see. I love it when I know that there are folks responding in the background. So that's good.
And I love this question. So I'm excited to see what the group thinks.
Okay, your options here are 8%, 16, 32, and 45, and you'll access that survey from your screen if you can see it. If you can't, then you might have to levitate in or use ESP or something. We're going to leave it up for just 30 more seconds. We're at 67%. I'm hoping I can see it. I see us hit 70% for Maureen here.
I love the motivation wheel that we can see it turning more green.
We can see it more green. That's right. Leslie writes, for 100% for the full 23 years of my career. So many of my colleagues are slacking and I have to pick up their slack.
I applaud you. I actually have in my notes on one of the slides, if you are the unicorn that is charting consistently and, oh my goodness, for 23 years, you should give yourself a shout out. You go, Leslie.
She's human AI at this point. She's the human version. All right, everyone, let's go ahead and end the voting. Share the results. There you go, Maureen.
So you guys were very, very divided between 16% and 32%. So kudos to those of you that guessed 16%. Sadly, 16% is the right answer. And that's, I think, for all of us, a really tragic number, but I get it. Please know that there is no judgment here. I absolutely understand why we have this problem, but I wanted to start with this question so all of you recognize the magnitude of the problem as well, that for all the perio that we have in our patient base, we only have 16% comprehensive charts. So again, the goal here was to help you see the magnitude of the issue. All right, let's go back to our slides. So I saw this posted on a hygiene site last year. Many of you may have seen it as well, and I just loved it. This picture summarizes the current state of periodontal charting better than anything I could have generated. If you're struggling to see it, it shows the hygienist trying to type on her keyboard with her toes, entering her perio chart, and she is complete with infection control barriers on her toes. So I just think that's priceless. And while it's humorous, it also reflects the struggle that hygienists are having across all practices, in that there's so much to do and so little time. So again, I want to make sure for my hygienists in the audience that I recognize the problem here. I knew as a hygiene leader at Aspen that I was asking more and more of hygienists. You know, when you add sleep apnea and saliva testing and 3D scanners and, oh my goodness, lasers, you name it. There are so many things that we want as part of the hygiene appointment, and they're all important. They're all great patient care paradigms, but I know for most of you, the appointment length hasn't changed any, and absolutely, this is the difficulty. So my goal here is to certainly help you get more comprehensive charts, get better at it, feel more confident at it, and then my colleague Shelley is going to come in and help you understand how we can do it more efficiently, more often. Okay. Just adding to the identifying the problem here, you saw in the last slide, a study published by the Journal of Perio indicated that only 16% of records had adequate perio charting. Similarly, a study by NIH found that only 1 in 5 charts had necessary information to make a periodontal diagnosis. And I'm going to refer back to this NIH study later on in the slides, because again, there's just so much need for all that perio information, including the risk factors, the full chart, and a perio diagnosis. Interestingly, some of what I think the issue is around perio charting is a bit of a paradigm shift in the value around perio charting. There are hygienists and dentists and educators who are questioning, do we really need to perio chart? Now that we can certainly see radiographically and with AI what bone loss looks like, when we know that there is some concern about moving biofilm when you're charting, there's some question about whether it is a necessary task. And I think we can dive deeper into that as we talk about the future of perio charting. But for right now, it's still the gold standard. It's still what most insurance carriers need. And we want to make sure that until we have a better solution, that we're good at this one, good at the perio charting. All right. As I was preparing for this course, one of my colleagues posted this on LinkedIn, and I thought it was priceless, and it validated what we're talking about, validated the issue. She posted that she gets all excited, her reaction when she sees offices that are staging and grading. And several of my other friends and colleagues joined in and said, yep, we're not seeing it. When we're doing office visits and office audits, we're not seeing complete perio charting. We're lucky if we see bleeding and pocket depth. We certainly aren't seeing staging and grading. And when you think about it, we're 7 years into these AAP guidelines. They came out in 2017. And the fact that we're at 2024 and we still have so little adoption of AAP guidelines, staging and grading, it tells me certainly that the timing is a factor. But my honest opinion is that we've overcomplicated staging and grading a bit. And one of my goals for today is to truly simplify it for you and hope that I can give you some tips and tricks to make that staging and grading a little faster. Okay, so let's talk about standard of care. Standard of care is really defined as a set of expectations about the degree of care that a dental professional would do consistent with other clinicians in the same situation. So it's a little bit about, hey, what does the collective do? But it's the set of expectation about the degree of care that a dental professional would take in a similar situation with, again, with another competent clinician. It's a little bit of a wordy definition. More importantly, I want you to take a look at what does it mean when you have to prove malpractice, or what concerns you as a hygienist or a dentist. What would be looked at in terms of malpractice when it came to perio charting? So to prove negligence, you need to show that a duty of care, what the duty of care is that's owed to the patient. Was that violated? Was the standard of care violated? Meaning, did this clinician not do what other clinicians would do in a similar circumstance? And as a result of that, was there an injury? And was it caused by substandard care? So having said all that, is hoping to give you a background about what defines standard of care. The good news for all of you, or I think it's good news, is that our governing bodies are really pretty aligned on what the standard of care for perio charting is. And what that looks like is once a year, comprehensive 6-point perio charting on all patients with adult dentition. So whether you are looking at AAP, ADHA, ADA, they are very aligned that the standard of care here, what you should be held accountable for, is one time per year, a comprehensive 6-point perio chart. Okay. More importantly, what these folks all align on, and this was reiterated with the AAP guidelines, is that knowing that folks with perio are more susceptible. They need to be monitored at a higher frequency. So the second piece of the standard of care is if you've identified risk factors for perio, or if we already know that this patient is a perio patient, has a history of perio care, we are compelled to chart them more frequently, monitor them more frequently. One of the conversations that I had with insurance carriers while at Aspen when it came to reimbursing for periodontal maintenance was that many of the carriers said, hey, look it, we're paying you or reimbursing you a higher fee for the monitoring of disease progression. Then they were pretty frank saying the physical treatment, the scaling of a patient is pretty similar for a prophy and for a perio maintenance. So the reason we're paying you a higher fee is because we are expecting that you are going to monitor that patient's disease progression. And that means quantifying where the bone loss is, where the bleeding is, and again, how they have changed over the course of time. Okay. I'm going to pause. I saw a question coming in. So you said about the age of being 18 years old. I think very often people use that as the certainly the adult age, but I will say that many of the documentation that documents that I found alluded to the fact that if you have adult dentition, you should perio chart. And I know that many of you have certainly seen, juvenile perio or, cases of certainly extreme ANUG and types, things like that in younger patients. So I would say, based on your assessment overall of a teenager, you may want to consider perio charting as well. But yes, 18, I think, would be truly the standard of care. I hope that helps. Okay. So we've talked about the when of the perio chart, how often it should be done. We've clarified that the expectation is once a year for adult patients and more frequently for periodontally at risk or periodontally involved patients. Now let's talk about the what of the perio chart. And again, please know that I am not suggesting that you all don't know this. I'm suggesting that there's a possibility you haven't had to exercise these muscles and you need a refresher. Hygiene school and hygiene boards were 40 years ago for me. I needed a refresher, and I think some of you might as well. So what's considered the gold standard here for a comprehensive chart? You can see that, again, the AAP, ADA, ADHA align on you need not only pocket depths and bleeding, which is what many of us do, but also suppuration, mucogingival relationships, recession, attachment loss. You see below gingival health and disease, distribution of plaque and calculus, bone loss, mobility infirmitus, and furcation involvement. So that is what right looks like. All those things are the expectation for a comprehensive chart. And many of us have just gotten out of the habit of checking for fremitus or checking for mobility or looking for furcations, and we want to touch on that. I see a question also, is PSR still used? And I will tell you that as a person who grew up in the hygiene world in the 90s, I did PSR a lot, but I would say it is considered an antiquated technology. It's really not the gold standard, not legal. Is it better than nothing? Sure. I want to be honest about that. Anything that you can do in your charts to quantify that you are checking for perio is better than no notes at all, but it is not, it's not considered the gold standard. And I'm sorry, somebody asked, what is AAP? American Academy of Periodontology. So thank you for asking that. And I'm sorry for using the acronym. Okay. When we touch on documentation of bleeding, plaque, and calculus, there's so many things that I want to point out here. Seems very simplistic, but I want to make sure that I'm touching on all the things you need to have a successful perio chart. Many of your patient management systems or your charting systems don't have a place to indicate plaque and calculus. Some do, but not all. And I think as a result of that, it often doesn't get described. It doesn't get communicated or documented. And as you saw in the previous slide, that is an expectation that there is a description about the plaque and calculus. So you want to make sure that you've got your bleeding points, you have where the plaque and calculus is, and more importantly, location, severity, quality, written description. So what does that look like? Your notes should say that it is localized, it's diffuse, it's interproximal, it's throughout, the severity of whether it's profuse bleeding or it's latent bleeding after probing, what the quality of the calculus is. Is it supragingival and light and localized, or is it throughout subgingival tenacious calculus? Many of you are probably doing this, but if you're not using those descriptors, I would encourage you to, so that you have a good, solid, defendable document that you're working off of. And I would say if your PMS or your charting system doesn't allow you to capture some of this in the actual Perio chart, that you might want to customize your templates so that you can add some of these things about the quality, location, and severity of these items. I also want to make sure that I mention bleeding percentage. I know that the 4342 code, the gingivitis code, 4346, is being severely underutilized. I saw this when I was at Aspen, and I have certainly seen it in my work at Denti. I know that we are not using that code because we're not calculating the percentage of bleeding. And I would say to all of you, if you take one thing away from this, make sure that you are assessing your bleeding and quantifying it, so that if the patient has greater than 30% bleeding, that you are having the right conversations and that you are moving that patient toward a gingivitis treatment. To me, it's important for the patient education. They need to know that you're seeing early signs of disease. It's important that we intervene at the earliest stage and we treat the gingivitis when it is reversible. And I know that the calculation can be difficult, but you kind of can ballpark it to some degree, and many of your systems do quantify the bleeding. If they don't, I promise you that our system does, and Shelley will tell you more about that. But regardless of whether it is automatically calculated, I want to make sure that you are capturing it, and for your own sake, that you're getting reimbursed for the work that you're doing, that you're not doing bloody prophies and work that is not getting reimbursed properly, and certainly that the patient is leaving with an understanding of where their disease state is. I'm going to pause for a second also and go back to my comments about standard of care, because one of the other things that is important from a legal aspect is that the patient has autonomy, and that they have been informed and they've had the right to participate in all the discussions around their disease state. And we're going to talk about how important this Perio chart is in patient education, but I want to make sure that your patient is aware that they have gingivitis, what stage they're at, and all of this documentation is a piece of that. I'm reading some of the comments here. Somebody said, the dentist I work with despised the 4346 code. I would love to know more about that, if you can expand on that. And somebody asked about the 30% bleeding sites. So it is truly 30% of the sites in the mouth, including all the 6 sites around every tooth, that 30% of them have bleeding. When you have identified that, then the patient certainly qualifies for that 4346 code. And I know for many offices, it also allows you to use some of your other modalities, use your antimicrobials, your rinses, your home care tools to get that patient on the right path. So as well as being a patient education piece, there certainly is a revenue piece there as well. We'll touch on that theme a couple of times. And I know that I'm passionate about this topic because I'm already giving you information that's on slides, 10 slides from now. All right. One last point before I go off of this slide. One of the things that I came across in preparing for the course was that lawyers suggested that on the recare visit where you're not completing a Perio chart, this information is even more important. So think about that when you're not, you've done your Perio chart 6 months ago and now you're on the recare interval, whether it's perio maintenance or a 6-month recare, and you're not intending to perio chart, the quality of your notes at that visit is actually more important. So just a word of caution there. Somebody mentioned that they stopped using the 4346 because carriers weren't paying. I certainly know that every insurance carrier is different, and there is certainly sometimes limitations about how often they will pay it, whether it's a once in a lifetime benefit. But try not to get too discouraged. There is reimbursement for the code, and hopefully I can set you up for success there. All right, let's get back to the basics here on mobility. I think Rachel, one of my colleagues from Denti, is on the call also, and I know that she gets asked about mobility. People just honestly can't remember what the criteria is. And so when we're encouraging them to fill in all the fields, including mobility, hygienists will say, I don't remember what class 1 is. I don't remember what I'm supposed to put in that box. So let's review. When you're testing for mobility, which as you probably recall is done with the blunt ends of 2 metal instruments, applying pressure to the buccal and lingual of the tooth. When you do that and you assess for movement, if you can move up to 1 millimeter in any direction, that is your class 1 mobility. If you can move in more than 1 millimeter, then it is a class 2 mobility. So again, movement, and I'm talking with my hands, movement more than 1 millimeter is a class 2. And if when you're assessing the movement, you get something that is suppressible or depressible into the socket, then you're going to chart that as a class 3. So class 1, up to 1 millimeter in any direction, class 2, greater than 1 millimeter, and class 3 is when you can depress into the socket. Okay. All right. Hopefully that jogs your memory a bit. And we're going to talk about fremitus. My colleagues at Hygiene Edge, I think, did a beautiful job with a video on how to test for fremitus. Another parameter that you probably haven't thought about since hygiene school, and I thought it would behoove us to watch this and get a refresher.
A tooth with fremitus has excess vibration of the tooth due to premature occlusal contact. Often it will have some mobility along with it as well. This is a test for fremitus, and it's usually done when a patient reports hitting high in a tooth for no apparent reason, and it will be done along with an occlusal analysis and adjustment by the dentist. So to determine whether a tooth has fremitus, sit the patient upright and stabilize the patient's head parallel with the floor, and then you're going to press your index finger on the cervical third of each maxillary tooth, starting with the most posterior tooth, moving forward tooth by tooth throughout the arch. On each tooth, have the patient tap their teeth together with their regular bite. Then note any teeth where actual movement is felt, and you can actually use a table to determine the degree of fremitus, as shown here.
Awesome. Before I move into the furcations, I want to make another comment that was sort of a theory in my head, and it's been confirmed by talking with a lot of other clinicians. While mobility and fremitus are not something that I think hygienists typically check every visit, we're in an age where patients can get do-it-yourself aligners and do it at DIY snap-on veneers and DIY night guards. And unfortunately, these things are readily available from Amazon and online. And I think we're seeing that patients are using some of these appliances and perhaps not telling us. And so I think it's important that we check for fremitus and mobility, because I do believe there's an uptick based on some of these DIY dentistry at home. I would love for you guys to share your thoughts if you're experiencing that in your office, if you're seeing patients using some of these things and as a result having some occlusal trauma. Okay, let's talk furcations. I think certainly a frequently asked question. Much like mobility, when hygienists are populating a chart, they will share that they cannot recall the different classifications and how they're differentiated. So I wanted to make sure that we touched on that. So when you're looking at furcations and you're going to enter that into your perio chart, if you do not see any bony involvement and you're seeing just slight cratering, really just an effect in the soft tissue, that is your class 1 furcation. Again, no radiographic evidence. You can't get into the furcation with your neighbor's probe. You're just seeing slight cratering of the soft tissue at the furcation. That's your class 1. When you can access the furcation from one surface, but not all surfaces, that is your class 2. So again, you've got no radiographic or very little radiographic evidence, but you have just some access from one side of the tooth. Your neighbor's probe is a partial penetration. That's your class 2 furcation. Looking at your class 3 and your class 4. The class 3, I think, is the one that everybody forgets, and that is a true radiographic bone loss within the roots, but it is covered by soft tissue. So you don't have access to it with your neighbor's probe because of that soft tissue blocking it, but you do have a true bone loss furcation involvement. And class 4 is the one we probably all remember as that through and through tunnel where you have access through the soft tissue, access through the bone, and your neighbor's probe can penetrate the entire length of that furcation. If there's any questions, certainly feel free to put them in the chat. I hope that some of these things are giving you some confidence so that you're like, oh yeah, I remember that. Okay, I can go back, I can enter that now. I feel more confident that I remember what the different classifications are. That was my goal here, just to set you up for success. Okay, I'm gonna get on my soapbox probably a little bit here about the AAP staging and grading. I know hygienists are wanting to feel like valued members of the team and level up. And many of my colleagues talk about practicing at the top of your scope. And to me, practicing at the top of your scope certainly includes systemic links and lasers and locally applied antibiotics and oral cancer screening is in sleep apnea and all those incredible things for patients. But I think it starts with making sure that we have assessed them properly and we've staged and graded them properly. And I feel strongly about this for a couple of reasons. One of them is that I truly believe patients care about this stage and grade, and they care about the information on their perio chart. I don't think all hygienists feel that way. I think there's some value proposition there that may be different, that hygienists think patients don't care. Because you hear, I just want to get out of here on time. I get that. I've been a hygienist. I've been in your shoes. I know that patients sometimes just want the quick, easy cleaning in and out. But I'm going to challenge you that our population is measuring everything. Everyone's wearing a Fitbit. Everyone's wearing an Apple Watch. Everyone's wearing an Oura Ring. And they're measuring their breathing and their oxygen and their sleep and their cycles and you name it. And they want to know what's happening in their body. And I have witnessed what happens when we give them that same information about the oral health. They do want to know. They want the perio chart as a report card. They want to know their progress. And so I truly want to inspire you about the importance of that patient education in the perio chart and what staging and grading means for that. I think saying to a patient, you have a little bit of bone loss, I'm seeing a little bit of bony change, see a little bit of bleeding, is not as impactful as saying to a patient, you have stage 2 periodontal disease. When patients hear stage 2, they can make the connection to what they understand in the cancer world. And it adds a level of urgency, it adds a level of importance and a level of ownership. And for that reason alone, I really want you to consider implementing staging and grading in your documentation, but implementing it in your verbiage with patients. Don't minimize the problem and tell them they have a little bit of bone loss or a little bit of bleeding. Tell them, based on your assessment, they have stage 1 or stage 2 periodontal disease and what that means for them. So again, on my soapbox, but I've seen how impactful it can be when we assess properly and when we educate. And I do strongly feel that patients want to know these numbers and they want to monitor themselves. Again, happy to see your thoughts. If you're seeing this happen in your practice and your patients are really wanting to know their numbers month after month, year after year, I'd love to hear your feedback. So having said that, what do you need to do? What data do you need to gather to properly stage and grade? Keep in mind that staging is determining the severity of the disease at the time that you are seeing the patient, and the grade is rating the progression of the disease. So for severity, you need to know the pocket depth, you need to know the gingival margin, you need to know the number of teeth that were lost due to perio, and you have to eyeball the radiographic bone loss. Okay, and we'll talk about trying to simplify that in just a moment. For your grading, to determine progression, you need the patient's age, ideally their A1C, but we'll talk about what you do if you don't have that, their tobacco use, their plaque control, and any medical complications. So this is the table stakes. This is what you need in order to stage and grade. And I feel like one of the reasons it's not being done is because we're not capturing enough of the information to set us up to stage and grade. So I want to make sure that you're aware of all your tools, what you need to properly stage and grade. Once you've captured that information, I tried to simplify this chart here. I actually took this from a journal article of a couple of periodontists who I thought did a nice job of boiling down the staging. Before I talk about the bottom of the slide, I want to mention that one of the common questions or common mistakes, I think, when it comes to your clinical attachment loss is people forgetting to subtract when you have gingival enlargement. So I think everybody knows you want your pocket depth plus your gingival margin. You add those two for your clinical attachment level. But if the gingiva is enlarged much beyond the CEJ, you want to enter that in your perio chart as a negative number so that you get accurate clinical attachment level. So I wanted just to mention that because I think that gets confused or overlooked quite often. But I promised you to try to simplify this. And what you're looking at is if you have clinical attachment loss of 1 to 2 millimeters, you're eyeballing the root length and the bone loss, and it's up to 15% bone loss, very early bone loss. That's your stage 1, typically treated very effectively with SRP. But again, 1 to 2 millimeters of clinical attachment loss, up to 15% bone loss, only horizontal defects, that's your stage 1 patient. When you get into 4 to 5 millimeters of attachment loss, or that true first third of the root length, so 15 to 33% of bone loss, then you're looking at a stage 2 patient who certainly can still be treated with SRP, but may require some other types of adjunctive therapies. Then when you're looking at your stage 3 patient, then you're in that middle third of the root between more than 33% of bone loss. You're looking at 5 millimeters of clinical attachment loss, and these patients may need more periotherapy, surgical intervention. And when you get into your stage 4, that's when you're really talking about primarily vertical defects, greater than 5 teeth lost due to perio. And those folks are probably going to go into, a prosthetic type of treatment plan or something more invasive. So that hopefully simplifies the stage piece for you. Again, you're measuring your clinical attachment loss, you're eyeballing your radiographic bone loss based on root length, and hopefully you can pretty quickly assign that stage. When it comes to grading, I have something that I think is particularly helpful that will simplify this for you. First of all, know that the AAP has determined that 80% of patients fall into grade B. What that means is those patients are losing bone at a moderate rate of less than 2 millimeters over 5 years. That is what the AAP deemed as moderate rate, less than 2 millimeters over 5 years. And so 80% of the time, if you mark your patient as grade B, excuse me, as grade B, you're going to be spot on. But you may ask, how do I determine whether they go to an A or a C? Now, the AAP gave you a calculation about bone loss over age. I don't think anybody's going to do that. And oftentimes you don't have the A1C information. You probably know about tobacco use, and certainly excessive tobacco use would move a patient to a rapid rate or a grade C. But in my hygiene brain, what I think is helpful is you want to look at the biofilm and the level of destruction. Does the amount of biofilm make sense with the level of destruction? Hear me out here, because this makes sense to me. When you see a patient, and I can think of many of them in my private practice, a patient that comes in and they are covered in plaque and calculus, and you're like, oh God, get me the Cavitron. When is the last time this patient brushed? And they are covered in biofilm, but you scale them and the tissue underneath looks rock solid. There's not even bleeding. They haven't had any bone loss. And you're like, how in the world is this person having no perio issues with the amount of biofilm? That is your grade A patient. They're going to have a slow progression. They have a great immunoresponse. They're fighting off the pathogens and they're not having destruction. So their level of biofilm does not equal their level of destruction. On the other end, you've all seen those patients that tell you, I'm brushing, I'm flossing, I'm using my water pick, I'm using rinses, and you don't see much biofilm, but they bleed profusely. They have that red complex bacteria. They have, other issues, probably some other medical compromising issues, and they are bleeding profusely despite the lack of biofilm. That is your patient that's going to be a rapid rate or a grade C patient. So I'm hoping to simplify that for you, that if you don't know the information about the A1C and you don't want to calculate their bone loss over their age, really look at, does the biofilm equal the level of destruction? I hope that makes sense. Okay. So we've talked about the when of perio charting, how often. We've talked about what should be in the perio chart, reviewed some of those parameters. I promised you that we would touch on the coding. One of the frustrations for teams is that you spend all this time creating a comprehensive perio chart and you don't necessarily recoup that expense. And I'm going to challenge that theory in a couple of slides, but I do recognize the reality and the challenges around getting reimbursed for 0180. Hopefully you've read this definition, and what you see in blue there is really the differentiator. I'm reiterating that you cannot just simply chart your pocket depth, chart your recession, and charge out an 0180. That is not considered a comprehensive chart. By definition, it has to have the probing, the charting, the occlusal, occlusal issues, gingival relationships, oral cancer screening. You can read all of this, but know that that is what the expectation is for an 0180. And I'm going to give you more caveats here on the next slide. Oh, I forgot. I want to poll you first. So I really want your input on what the reality is in your office. How are you charting? How are you charging it out? And please, of any of the questions, please stay with me and join in on this question, because at nearly 1,000 people, or however many we're at, it's a great sample size. And the data and this information is important for you to know, important for Dr. Rawling and myself and anybody who's doing programming. It's important for us to know what's really happening out there in the real world. So please chime in on this question.
Okay, everyone, we're at about 35%. We have about 11 minutes left in the course, so we're going to give you a minute here to help Maureen out, help me out. We're at 45%. Thank you, everyone. Large class today and great questions, Maureen.
I'm thrilled to see all the comments in the chat box and folks helping each other out as well. It's terrific.
Okay, we're at 56%. Let's take a few more seconds here. Jolt the brain.
Yeah, please tell me I didn't lose you, halfway through. Come back.
Right.
Come back.
Right. Which scenario best applies to your office? We spot probe and rarely complete comprehensive charting. We chart annually, but do not charge a code or fee for this service. We chart annually and we use a generic code, or we chart annually using the 0180 code and with a fee for this service.
And Gina, I see your question about does this replace one of the other codes? And hold that thought, because I'm going to answer it on the next slide. Thanks for the question.
All right. Let's go ahead and end just because of time here, Maureen.
Yep.
If that's okay with you. I'll
Absolutely.
share the results. Okay, thank you, everyone.
Okay. So looks like, looks like about 7% said that they spot probe. I expected most would say we chart annually, but we don't charge a code for this. That I think is the norm, so not surprised there. And then we have 13% that chart annually and use a generic code. And we only have about 6% that are using the 0180. So truthfully, it's about what I expected from the question. So thank you for taking part. I do think that there's an opportunity to recoup some of this revenue on the 0180. I'll also say that I think there's opportunity to recoup from perio charting in general, but we'll get to that. But when it relates to just the 018 code, I want to give you some guidance there. So I'll go back to my slides if we can. Okay. So I already have mentioned it is not a code for simply charting pocket depth and bleeding. It needs to be that comprehensive, full parameters, all the things that we have talked about throughout the course. That is what's considered necessary for the 0180. To Gina's question, the 0180 cannot be charged out on the same day as a periodic or a comprehensive exam. And so you would be using this again on those off recare visits where you're not doing a periodic exam or you're not doing a comprehensive exam, then the 0180 could be considered. So yes, Gina, if it's done at the same time as one of the other exams, it would be likely down coded to the comprehensive or the periodic. A higher fee can be charged for 0180, so that is considered acceptable. And I wanted to mention to you that in my research for this class, I found another author who had researched that for Delta Premier, I don't know how many of you work with them, but their average reimbursement for a periodic exam was $48. But when they did reimburse on a periodontal exam, an 0180, they reimbursed as much as $82. So there is a significant difference there. When used properly, you can recoup some of that expense. So I wanted to share that. The reality is the claim is often downcoded to the 0120. Many plans have a reimbursement that it's every 24 months or perhaps a once in a lifetime benefit. The other question that gets asked is, can it be used by a general dentist? And yes, it absolutely can. A general dentist can submit for this code. How the insurance carriers handle that on the back end, is different by carrier, but you are legally allowed to use that code. The caveat again is that it has to be completed at the standard of a specialist. So you need to do it like a periodontist or a specialist would do it in order for them to consider reimbursing the code. Okay. All right. Expanding upon that just a bit. So I want to make sure we get through all of our slides here. I included this because I think these certainly differentiate a typical periodic exam versus a perio exam. And so I would encourage you, if you're going to try to capitalize on that 0180 code, that you also comment on these conditions. Any abnormal color, the periodontal biotype, which is something you probably haven't thought about since hygiene school. You want to comment on the gingival recession. We've done that already. The lack of keratinized gingiva, any changes in the vestibular depth, and frenums. I think we overlook these a lot because we're in a time crunch, but if you're truly trying to take a comprehensive look, these factors should be mentioned. I'm going to go back to perio biotype because it was also a refresher for me in preparing for the course. And I think these are really important. Outside even of your documentation, I think this is a good refresher. So your thin scalloped biotype is the one that is most susceptible to periodontal disease. So when you are looking at a patient, you see that, as my professor used to call it, that horse tooth look with that very thin gingiva, that is your thin scalloped and more prone to disease. The thick scalloped is much more common. I think more than 50, I think it's 57% of the population has thick scalloped perio biotype. And when you see this type C here, the thick flat biotype, it's very often associated with occlusal issues, as you see in this picture as well. So it should get your brain thinking about clear aligners and about occlusal relationships when you see that thick, flat perio biotype. I'm encouraging you to level up here. You can see that I'm digging in and encouraging you to use descriptors and phrases that show that you have truly done a thorough assessment of this patient's perio condition. All right, let's get into some legalities as we wrap up here. Perio is the 5th most common negligence case. And as you see in the slide here, the majority of these cases where somebody was sued for failure to diagnose perio, there was not perio probings recorded and available. It simply is an issue, and it's becoming more of an issue, not scaling and root planing, but the failure to diagnose perio becomes a problem with all of the extensive restorative that we're doing. When we're placing implants and we're doing all-on-4s and doing these big cases, and we have not truly documented the patient's perio disease or treated it appropriately, there's just very, very big risk there. So you need to CYA. Last, if we have time, I don't know, Dr. Relling, if you think we should skip the last question or whether we can, if we have enough time to get that in.
We're going to push the envelope here. That's okay.
All right. If you guys can answer quickly, I really would love to know your experience about the legal issues around perio. Have you ever been sued? Have you been denied reimbursement? So please read those choices carefully. I can read them for you here to try to expedite. So please answer if you've been denied reimbursement of SRP or perio maintenance due to insufficient documentation. Have you been required to repay an insurer for SRP because of insufficient documentation? Or please be vulnerable and transparent. Have you ever been sued due to failure to diagnose perio?
These are important questions, so please chime in, folks. We have a couple more minutes. We're going to be posting the code here. Someone has, what if none applies? Then what do you think, Maureen? If somebody feels none applies, how would you like them to address that?
I guess they don't have to chime in if they. You
don't have to chime in.
If they've been lucky enough not to encounter any of these, you get a pass.
Yeah. Got a few none applies. Okay. For those of you that are none, we won't post all the nones. Did you mention whether documenting? I'm going to post that on the other side.
Oh, yep. Hold that thought. Next slide that I want to make sure I get to, but in terms of documentation.
Okay, we're at 40%.
Okay, so
please go ahead and chime in. We're going to end the voting here in 3 seconds. 1, 2, 3. Almost. There you go, Maureen.
So it looks like many of you have been denied reimbursement, which was certainly my experience in private practice and at Aspen. So not surprised that you guys are experiencing that. What I will tell you is that I had the opportunity in preparing for this course to talk with a dentist who's also a lawyer. And the second scenario that I shared with you, where insurance carriers will do a full audit of charts and actually require lump payments back to the insurance carrier if they feel that you don't have sufficient documentation. And I don't want to be a fear monger here. I don't want to create a scare tactic. I just want you to be aware that he shared this was happening with increased frequency. So all the more reason why you need to be buttoned up with your perio documentation so you can protect your revenue. All right. We had some questions about mitigating risk and I think rights and refusal. So great place to start wrapping up. Make sure that you're taking your radiographs according to risk factors. And as somebody mentioned, documenting refusal. If a patient is refusing radiographs, refusing perio charting, not only should you document it, you should have the patient sign the chart. There is great power in having a patient sign a chart. I've witnessed it firsthand. There's something about making them sign, yep, I'm not doing this. I'm refusing to take the steps that you've advised me of. There's power in that. So please do that. I mentioned documenting the perio refusal. Also make sure that you include copies of your referrals in your charts. Document every periodic exam. What I mean by that is not that you're saying periodic exam, actually put findings of the periodic exam. This came up a lot in the research around litigation, that people would charge out a periodic exam, but there was nothing in the clinical notes that actually reflected findings. So even if it's just saying, no decay, no change in probing depths, whatever it might be, make notes that show what the actual findings were of your periodic exam. Don't just write periodic exam. Complete comprehensive charting. We've certainly talked about the standard of care there, making sure that you are charting once a year and more frequently on patients that are unstable. And the last piece that I want to say is that you not only want to document it the first time you've had this conversation around perio refusal, but you want to document it every subsequent conversation that you have with that patient. You want to say that you have reminded them there's been multiple times where you have educated them on the state of perio and they are either refusing treatment or what that looks like. I also want to mention for the doctors on the call, patients can refuse treatment, but they cannot force you to do substandard care. And we're running up on time here, but I want to mention that I had a very good friend, a doctor friend, who had a patient who was really pushing him to do a crown on a periodontally involved tooth. And the doc didn't feel comfortable about it. We had done a full perio chart, documented the presence of the perio disease. The patient was frustrated. He left the practice, went to another practice down the street, got the crown done by somebody else. The crown failed within a year because of the perio. The patient sued that doctor. The doctor tried to say in court, well, you didn't have perio at the time I did the crown. And they came back and subpoenaed Aspen's records because the patient said, I did have perio. I know I did. Aspen Dental told me that I had perio, and they came back and subpoenaed our records. And that doctor lost the suit for having done that crown on a periodontally involved tooth. So just want to share that. It's just behooves you to not let the patient force your hand in doing work that you don't feel is good, that you feel is negligent. They can't force you to do negligent care. All right. I'm going to jump ahead here because I'm already up on time. I'm going to jump ahead to future state so that I can tee up Shelley. What I think will happen in the future certainly is more and more voice-activated perio charting. You're going to get to see that demonstration in just a moment that will allow you to be much more efficient and more comprehensive in your perio charting. There are more and more listening devices coming on the market that capture the entire patient conversation and translate that into notes. So some of that is certainly going to help you with documentation and timing because all of it will be captured and translated into AI-generated notes. We're going to see more and more DNA sampling. I know some folks mentioned in the chat that they're doing salivary testing, but I think we will get to a point where perhaps even robotics or 3D scans will be used to make perio assessments and perhaps decrease the importance of perio charting. And I think we're ultimately trying to get with electronic health records. I mentioned this to you that I was going to come back to that NIH study. NIH's purpose in that study is they're trying to see, can we pull enough information from medical charts and from dental charts where we can really make good predictive analysis of what a patient's path is going to look like for their perio health, their dental health. And so the more we can complete our records, our medical records and our dental records, we have the opportunity, I think, through record sharing to really get a good predictive analysis. And I think this is the way it will go in the future for sure.
Full screen mode here. So if there's questions, I may not see them. There we go. So really quick, thank you for the intro, of course. That's me, Shelley, 25 years in dental, mom to 4 kids, dog mom to 3, and Glamma to that beautiful grandchild right there. So you can see my priorities, my dogs and my grandbaby now. So I want to talk about, there we go, a couple of things in kind of prepping for this. I saw that there were a bunch of dental assistants in here. Are you as a hygienist dependent on your dental assistants, or are you as the dental assistant doing marathons, running all over the practice to keep up with the need? giving more time back to patient education would probably be helpful for most of you. I was kind of seeing in those comments that I think you guys answered this question for me. Do you find it necessary to cut some corners? And I think some of your answers definitely said yes to that. And are you frequently short-staffed? I mean, that's what's happening in dentistry right now, is we are finding ourselves short-staffed more than we want to. So you're doing perio charts by yourself. Or are you on the flip side of that and you've tried perio products in the past and you were disappointed? So I say if you've answered yes to more than three of those questions, then you're certainly prepared for what I am going to show you. Just a quick agenda here to cover for the sake of time. There's a ton of time constraints in the modern dental office right now that we're facing. Are there AI solutions available for the RDH? The answer is absolutely yes. Patient education with visual aids has always been I'm a huge fan of them. And then the ability to perio chart with AI, and I'll have some final takeaways and tips and some cool things for you at the end. So I put this girl with her hair ripping. We're all at that point in dentistry right now. The time restraints and the demand in a modern dental office is pretty crazy at this point. The time with the patient in the chair is being reduced and crunched. The demands for consistent diagnosis, patient care, complete charts is increasing, but your time is decreasing. New patient exams are being reduced from 1.5 hours to 60 minutes. And more recently, I heard one DSO group is pushing new patient exams to 50 minutes. And how in the heck do you do that? At the end of your day, I'm sure you're tired, burnt out. You feel like your patient care is compromised, and there's just really never enough time in the day to complete those comprehensive exams and notes. So there are AI solutions that are available that are going to help you increase patient care and better your patient experience and give you, as the hygienist, valuable time back. I am going to stop this for 2 seconds. I'm just going to flip over here. I have a little video that I would like to show all of you, and I'm starting it kind of midway through so that you don't have to hear the whole thing. But you can essentially now do a full perio probe in about 5 minutes. Here's just a portion of it. And this is using AI, Denti.AI. This is one of the practice management solutions that we do integrate with. So if you're using Dentacon, Dexis, Open Dental, CareStack, all of the big ones, we fully integrate so you can access your patient perio chart and use a voice that goes directly into your practice management. So let me give you a little sample of that here.
323, 444, repeat 2, separation 13 buckle, furcation 15 buckle class 1, pause, resume, 1098, 765, 433, 333, 323, 322, 222, repeat, bleeding quadrant 2, mobility 15, grade 2, 232, repeat 2, 323, 333, 334, 444, repeat, jump gingival margin, jump 1 buckle, 111, jump 12.
All right,
Save chart.
There we go. So
Once
at the
you
save
save
chart,
it brings up the oral health status.
let me jump back over. You can see here that you can very easily do voice perio charting at this point. At the end of your voice perio chart, it's going to take and collect all of that data and compress that into an oral health status. As a former treatment coordinator, for me, this is also the best part, is explaining to our patients what their oral health actually looks like, and we can show that to them visually. Let me switch back over to this here. Okay, so that oral health status, I want to kind of briefly talk about. It really gives data-rich patient summaries for your patients to understand their diagnosis. This was a big thing when I was chairside. Hygienists would leave the room, DDS would leave the room, and the patient would immediately look at me and say, "I don't understand anything that they just said." So this is something you can print off and give to your patient so that they can understand it. But it's going to go through and highlight their perio stage. It's going to calculate bleeding for you. You can mark their grade right here, sorry. And then it's going to assign suggested treatment. There's suggested.
Oh, I think you might have frozen.
Got it? Okay, sorry. Adjunctive therapies. The AI will, hopefully you can hear me now. Yes. Okay. There are AI notes that are patient facing, and then there's a really nice odonogram that's going to help them tremendously. This will highlight in red the areas of concern. There's a ratio in here also for the number of bleeding sites and probing depths with 4 millimeter or more. So you're really generating a beautiful summary for your patient with the AI in Denti.AI, so your patient can understand their oral health a little bit better.
And Shelley, I just want to reiterate for the folks that stayed with me through the whole first part of this, keep in mind the beauty that Shelley just shared with you. It suggests a stage and grade. So as I talked about the complexity of staging and grading, the AI will do that for you. It gives you auto-generated notes. So as I talked about descriptions of your perio conditions, as you're talking with the patients, it's going to generate those notes. And so much of what is causing you time can be solved by using AI voice-activated perio charting.
I do want to remind everyone, excuse me, at the top of your screen is a banner to book a demo with Denti. If you tap on there, and I see a few of you doing that, we also put the link in the chat area. So book your demo and get a deep dive, and I'm going to give it back to Shelley here.
Yeah, Shelley's just plain fun, so you should book a demo anyway because she's just plain fun.
Yeah, I do get a little wild in my demos, that's for sure. And I'm like marathoning through this one just so I could get as much information in there. Anyways, it's twofold. It's helping the hygienist. Your patients are now sitting in the chair having a better experience. And at the end of that, they're getting this report that really puts their oral health into a nutshell. And I say always, as a treatment coordinator, if that scenario happens like Maureen was talking about, and dentist has diagnosed a crown on number 3, and you can see clearly here, number 3 also is an issue. This is going to help with those out-of-pocket conversations, those uncomfortable out-of-pocket conversations that we have to have with our patient to getting both of those done, because if they don't get it done, the potential there is to lose a tooth. All right, next one here. Sorry. Oh my goodness, I keep starting over again. Okay. So just some final tips, and I'm trying to be mindful of time here. You can get your complete full exam done in a lot less time. As I said, on average, hygienists that are using Denti.AI are being able to complete an entire comprehensive exam in about 5 minutes, unassisted, of course. Get more time back in your appointment, use technology to better your workflow, and design your workflow for less stress and better ergonomics for you also is really huge. For the long career, we need anything that will help our backs. So I appreciate you scheduling or dropping that link to schedule a time with me. I do have an offer, never offered this before, and don't tell my boss because I might have pushed the limits a little bit, but I am doing a one-time offer. If you order today, and I'll actually extend this link, I'll drop it in the chat. If you want to order it through Monday, I will throw in one free wireless mic. That's a big thing. That's about $100 savings. You will get a 30-day money-back guarantee if you're using it and it's still not working out for you. There's no training fee that's been waived. And yes, yeah.
Nope, I'm just want to remind everybody to tap on that banner at the top of the screen so they can take advantage of these bonus that you have today.
Yes.
We've got some questions coming in too.
Okay.
and Shelley, you're better at this than I am. I should know all of these, but there's questions about Dentrix Extend and EagleSoft. I answered yes to both of those, but if you want to kind of rattle off all of our integrations, that would be helpful.
Let me stop sharing so I can see those chats a little bit better, but yes. So EagleSoft, did I stop sharing properly?
Yes.
Okay, there we go. Yeah, EagleSoft, Open Dental, Dentrix, Ascend, Denticon is the one that I showed. Am I missing CareStack? All majors. There are a couple of older programs that we do not integrate with. If you happen to have a software that we do not integrate with, we do have a standalone product that would work for you.
Somebody asked about SoftDent. I don't believe right now that we've done SoftDent.
No on SoftDent.
So Eileen, I'm sorry about that.
Yeah, Eileen. So that would be our standalone. If you do book an appointment with me, I can show you what that standalone would look like. It's just as easy, if not easier, in that independent feature, but you wouldn't have that integration right where it writes into your practice management software.
Yeah, Eileen, I don't want you to be discouraged. What Shelley means is you can still use the tool. It just saves as a separate document that you would upload to the patient chart. So the tools are still available to you. You would just be uploading it to the patient chart rather than it fully integrating into your existing Perio chart.
Yeah. I saw ClearDent in there. That's a yes, and so is Curve.
What about Epic? I think we have, right. Those are some public health folks. Yeah. I feel your pain there. Doesn't integrate.
We're working on it. We're working on it.
We're definitely working on Epic. That's going to take a little tiny bit more time though, but yeah.
Okay. And again, if you tap on the banner at the top of the screen, you can bookmark that, take it back to your practices as well. Bookmark it to your device.
And then did you share the link if they did want to purchase from this? I'll only hold that link open through Monday.
Yes.
Okay.
And you may want to send out an email right away. We'll be giving you the list too.
Okay. I dropped it in the chat if anybody wants to grab it there too.
There it is. I will repost it here. Information for my office manager to reach out. Yes, there is a document in the course folder. So all of you have that. And you can take that back to your practice as well. What about tab 32 or Fuse with Patterson?
Fuse, no. Tab 32 we're working on.
Okay. Great comments for both of you.
Yes, Catherine, it is inspiring for the future of dental. This has been so needed in dental. I'll briefly talk about it. We just released our Denti.AI Scribe. This is another tremendous movement for the dental office, but we have developed something. It just goes right off of your lapel mic where you can have a casual conversation with your patient, ask them about how they've been, talk about anniversaries, birthdays, where they've been having pain points or what's been going on. And our software is going to take that and transcribe it and then flip it into your whole conversation. It's going to flip into a SOAP note or a template for your visit with your patient.